the beginning of every didactic on getting your CMEs and CE certificates. Neither Dr. Bhatt nor I have any financial disclosures related to the content of this didactic. Today we're going to talk about medication-assisted treatment and components of a successful practice, namely a team-based approach. So what does that actually look like? Well, we're going to talk about the importance of using a team-based approach rather than being a single provider to work with patients on medicated assisted treatment. We're going to go through some of the typical team members or recommendations for the team structure that's recommended for office-based Suboxone prescribing. We're going to describe those roles and responsibilities and address how administration for your facility can support you in building this team. And maybe even talk a little bit about how you can be creative in building this team if you don't have these team members actually in-house. So you have to sort of do some collaboration with other providers in the community or other professionals that are part of the individual's treatment plan. And then talk about how this could apply to you. So if there's questions at the end about how to apply this team-based approach, hopefully we'll have a few minutes to address those questions. So let's talk about using a treatment team. Why is it important? Well, the first thing that we want to talk about is a little bit of jargon. So addressing what some of the definitions are, because we use the word multidisciplinary and interdisciplinary kind of interchangeably. And what we're talking about with these treatment teams is something called integrated treatment. So that means multiple providers, so each having a different role, all working together. And this model of treatment has been shown to be extremely helpful and actually the gold standard approach by most regulating bodies for both mental illness and substance use disorders, and is therefore considered the recommended standard for people with a dual diagnosis, so those that have both a mental illness and a co-occurring substance use issue. Why is it so helpful? Well, it allows patients to receive combined treatment of all of the issues that they're struggling with to meet their psychosocial needs, their psychological, their psychiatric needs from one team that coordinates that care. So rather than having the patient kind of have to go to all of these different places to get those needs met, we're not expecting them to know even what those needs are. By having a team to guide that care plan and to work with each other, we're going to provide a more consistent message about treatment and recovery. And we're also going to help move patients forward on their treatment goals by addressing them kind of in lockstep with the other people that are working on those same goals. And like I said, there is a difference between multidisciplinary and interdisciplinary. And multidisciplinary is sort of like where an example of most of us have a care plan, whether it's explicitly acknowledged or not. We probably have a dentist, primary care physician, maybe we see a specialist for our headaches or whatnot. Well, these people aren't working in concert together. They're coming from different disciplines and they're part of our care, but they're not working together. That's different than interdisciplinary, which is where these people from different areas addressing different needs for one person are actually coordinating and communicating. And so they're sharing a treatment plan. And that's why it really is the recommended approach is to be interdisciplinary, bringing those different perspectives to the table to formulate a treatment plan and implement it together is the ideal approach. So here are some concepts related to developing this team. Recognizing that recovery in general, the big picture recovery that we're talking about with the patients that we're working with, is more than just helping them to experience symptom remission. That recovery really involves the development of meaning and purpose in someone's life. Long-term recovery includes helping people get to a place where they can engage meaningfully in the things that are going to allow them to avoid relapse. So gainful employment, connection with family members or loved ones, part of community involvement, spiritual practice, all of those things that are going to help them to be healthy and productive members of society, be able to avoid situations that might trigger a relapse. So not just decreasing symptoms, and stabilizing, but really moving into a greater appreciation and broader inclusion of meaning in their life. By including all of the people that work with those aspects of a person, so their psychosocial needs, helping them to get a job, helping them with case management, helping them with accessing their medical providers, their therapeutic providers, that's all crucial for really allowing folks to move into a recovery stance. The other thing is the shared treatment plan, and the treatment plan includes not just the multiple disciplines that are contributing to it, but also the patient themselves. And if the patient doesn't own the treatment plan, so knows what it is, knows what the goals are, and knows who on their team is helping them to achieve those goals, they're not going to be very likely to get to that next step. So it's one thing to have a plan. It's another thing to have an integrated treatment plan where the patient is a shared owner and has full responsibility for that plan. And that's really the standard that we're trying to get folks to. That's why it's important to have buy-in from administration and to have an infrastructure in place to promote the building of these teams and the maintenance of team cohesion, right? Because if there isn't time allotted or space allotted to allow these teams to develop and then communicate and coordinate with each other, then that's too much pressure on the individual providers to fit it in here and there, and it's just not going to get done, right? So there really needs to be a clear infrastructure in place to support team-based care. And the other thing is an expectation that these treatment teams will be guided by a shared treatment plan. So that treatment plan will be looked at and will be documented in as part of every clinical encounter or intervention. Because if we don't know why they're there and what they're working on, we're not going to be very successful of moving them forward in the future toward a really secure stance in recovery. So that treatment plan is the one thing that helps guide, that's the roadmap that all of the providers on the team use. So what are the components of a successful team? Well, the team structure includes who is on it. And so that's your core team, which is the client and all of the primary treating providers, as well as the extended team. And those are the providers who aren't necessarily part of that integrated treatment team. So they might have less frequent contact with the client. They might be part of a separate agency, or they might be a concerned significant other that doesn't actually live with or work closely with the client, but they're still included as part of some of those treatment goals. So thinking about who is on the team, who's my core team, and then who's part of the extended team members, and what vehicle of communication does there need to be in place for each type of team. And then what's the structure? Every team needs to have a team leader or manager, so somebody that is actually sort of the buck stops here, point of contact for the treatment plan. So they're responsible for making sure that this document as a whole is administered and managed appropriately. And they tend to be, doesn't have to be the doctor, doesn't have to be the therapist. It is just the person that tends to work with the client the most. So at ASAP, for a population of our folks, that's actually a nurse that is in that role, because they have the most frequent contact with the patients as part of dosing or doing different assessments, or they're doing check-ins with them. And then the other members of the core team might see them less frequently, but the nurse actually is the primary person running the team for that patient. And you must have some kind of a role where someone acts as a coordinator or recovery coach. And so they're the ones that set up the team meetings and make sure that the communication takes place between all of the treating providers so that things are tracked accordingly. What makes for a successful team is the ability to be flexible and yet have defined roles. So everyone on that team kind of knows what their role is, if they're on the core team or the extended team, and what thing they're bringing to the table. But if somebody's out or someone is unable to perform that function, people can step up and we can sort of exchange hats relatively flexibly in the service of benefiting that patient. So it's important to know your scope and role on the team, but you also need to know other people's role on the team so that you can jump in if you need to. So let's go through each one of these in a little more detail. So a team lead or a manager, it could be, really any of these professions. They are the consistent point of contact for the patient. So they're sort of the person that the patient has the number that they can get in touch with. if they need to make an appointment with the other members of the team, or they need to talk to someone, they at least know there's one person that they can definitely get in touch with. And they help to coordinate the communication between team members and the patient. So team members with each other, and then team members with the patient. They most likely have some patient care functions. So I think that's why they tend to be like the doctor or the nurse practitioner or the physician assistant or the RN or the licensed therapist. They have some care function in involvement with the patient. They're not purely an administrative role. They often will conduct support groups or provide individual support education. And a lot of the structures that are recommended in the literature support a similar program to what we do at ASAP, which is to have nurses in this role of team lead or program manager, because they can wear lots of different hats, and they tend to, like I said, have pretty frequent contact with the patients as part of the dosing piece, and that they've been shown to be highly effective in that role. So that's just something to consider. In terms of the recovery coach or the engagement specialist, this could be a different level of professional, could also be a nurse, could also be a community health worker, a medical assistant, or peer support specialist could serve in this role. It does require a little bit of training, so they would kind of need to be trained into the specific aspects of what we would be asking them to do on the team. But they help to connect to expanded services, and they tend to have a little more administrative duties. So they can help do things like prior authorizations, check the PMP, they maintain certain attendance logs. If you have contingency management, they might be tracking that sort of thing. And they might also provide some clinical duty support, depending on what their level of licensure is, or basic screeners, that sort of thing. They can also provide patient education and harm reduction. And they can also provide psychosocial support. So they can be the person that helps the patient with checking in, making necessary referrals to the community, doing phone check-ins to see how they're doing. So the engagement specialist and the team lead work really closely together. They have, they're kind of like a dyad partnership over this care team. And they might have some flexible roles with how they work with the patient and the team. But it's really important to have both of those. Now, in terms of some of those referrals for that extended team, this can be made by anyone, but it typically tends to be made by the engagement specialist, and that could be to any kinds of community peer-led groups, traditional healing interventions, higher levels of care like IOP or RTC, making sure that patients are routinely given information about crisis line numbers, harm reduction programs like clean needle exchanges, that they have access to various infectious disease testing services and treatment services, that they know where to get food resources, housing resources, utility resources, employment and education resources, and then what psychiatric and psychosocial intervention is available. Another important member of the team is the therapist. So this is somebody who has a degree in a clinical therapy of some kind. So that could be a licensed counselor, a licensed clinical social worker, a psychologist. Even in some areas, it could be a LADAC if that's someone that has some substance abuse counseling. But they tend to be someone that has at least some sufficient training in providing the evidence-based interventions that are recommended for patients receiving medication-assisted treatment. So that would include having a skill set in CBT, relapse prevention, motivational interviewing, understanding reinforcement or behavioral interventions like contingency management. Could also be people that can help with 12-step facilitation or smart recovery interventions. And ideally, you have an in-house therapist that is part of your team. But if not, if it's an external person, we want to make sure that your team is coordinating care very regularly with that therapist. That therapist would be considered part of the core team. Also be a member of the team would be a pharmacist, and that's someone that is responsible, again, for making sure that the patients have access to naloxone, providing education, that they know where to receive emergency services, that the physicians that they're working with have education on things like chronic pain management practices, and that they're part of the team that helps to identify high-risk patients or patients that might have some combination of medications that is going to place them at risk. So sort of monitoring what might be going on there. So that's the naloxone importance as well. And then having some sort of either APN, physician assistant, and or MD that can prescribe these medications. So these are interchangeable, able to provide a physical examination, help to maintain the medication management, again, providing education to the team and the patient. So I'm going to turn this over to Dr. Bhatt. I think you were going to talk a little bit about some of the specifics with the prescribing.
Great, thank you. Yeah, thank you, Dr. Maley. So taking over, so I mean, I think here, and a lot of this next slides are coming from kind of the Massachusetts collaborative care model, which has been studied a lot, published a lot, and really focused on how do we use a team-based approach to leverage our limited resources, right? And so this is really from them where they kind of broke down some kind of pretty important roles that clinics providing buprenorphine for opioid use disorder treatment may be functioning, and which staff should be, which team members should be trained in it, right? Again, with the idea being that people are kind of functioning to their maximum licensure and really supporting each other, working together to ultimately provide best care to our patients, even with limited resources. So prior authorizations, right? Again, as all providers know, can sometimes be all-encompassing and take a lot of time, right? So who should be trained in it? You know, medical assistants, front office, or designated staff who might be assisting with billing or prior authorization, right? So that makes sense. Prior notification, same staff, right? So kind of that does it, kind of doing those things together. Basic understanding of addiction, substance use disorder, all staff should be trained in it. You know, front desk, nursing staff, MAs, physicians, all of us should be trained in kind of understanding the basic principles. Also handling challenging behaviors, setting appropriate boundaries, learning to deal with our patients, learning to interact with our patients in a patient-centered way, in a helpful way. We all should be familiar with it, right? Similar with behavioral contracts as they may be needed, or addressing staff concerns, right, that come up. You know, ideally all staff are kind of equipped and are comfortable enough with each other where we can process these things together. Follow-up visit protocol, right? How do follow-up visits go? Again, nurses or MAs are often kind of running or allowing this to flow. Phone prescriptions, front office staff or any answer phones, right, and PMP monitoring is one selected agent for each site per prescriber. So generally, for example, what we do, for example, at our clinic is each provider has 4 different MAs or nursing staff who are their designated individuals who can check the PMP. So that way, when a provider goes and sees the patient, the PMP has already been pulled, the provider simply reviews it and is able to address any relevant concerns. Could you advance, Dr. Maley? Next, thank you. So going to the Massachusetts collaborative care model. Great. So this is the one that's really been, as I was mentioned, studied quite a bit. And really the idea came about because, you know, like all of us around the country, Massachusetts was dealing with kind of lack of capacity, right? Treatment capacity. So they kind of instituted this, and they found an increased favored physicians by about 375% in 3-year period. And also markedly increased patients who are receiving medication-assisted treatments or medications for opioid use disorders. And I do like to point out that, you know, because often there are these disparities, right, that we see across populations in who's able to access these evidence-based treatments. And in Massachusetts, one of the things they found was racial and ethnic minorities were especially able to access medications once they put this into place. And again, central to the whole process, that team lead, they use nurse care managers as kind of the team lead who helped organize treatment around it. And one of the interesting things they found was that having one nurse care manager combined with one MA, having that core team, they were actually able to treat about 125 patients, and it was financially viable and sustainable. Next slide, please. Right. So again, this one kind of breaks down how they did it. So they really used the team approach. starting with the initial screening assessment, which was often done even over the phone to see if the patient really met criteria for opioid use disorder, may benefit from treatment. And this was really carried out by the trained nurse care manager. And then, once a week or twice a week, the whole team meets together to review the chart, right? To see how we can come up with essentially a treatment plan that would then follow the patient. And then the chart review, once the patient comes in, the physician or the other provider reviews the chart, does a physical examination, gives the diagnosis of opioid use disorder, makes the decision. And actually in this model, which we don't do at ASAP, even the prescription is generated by the nurse care manager, and the MD, which is what they use, simply reviewed and signed the prescription. And of course, the pharmacy then filled the prescription, right? The induction, whether they were done at home or in the office, was really, again, carried out by trained nursing staff who educated patients, assessed patients, and walked them through the entire process. And then the support was provided, again, primarily by the nurse care manager and MD backup. This piece is interesting. I'm familiar with some of the models utilized by some of the IHS clinics or even some of the tribal programs that have utilized a trained peer in this capacity for support during the induction of the buprenorphine. And to really good effect. So there may be other ways of looking at it, right? And then again, the follow-up primarily done by the nurse care manager with really MD serving as the backup, really doing the essential function of checking in on the patient, answering any further concerns, and making sure the prescription is provided. And the idea was that if we do this, there are so few trained providers, even, certainly when this came out and even now, right? Even in 2020, about 5% of all providers in the United States are waived to provide buprenorphine. So that resource is really limited, right? And also reimbursement rates can also serve as a barrier from MD doing a lot of these things, right? So the idea became that, to really use the team approach. Next slide, please. And again, I think this is just, I've included really as kind of what that initial screening assessment done by the nurse care manager was. Just for reference, I've included that. You can go to the next slide. Yeah. So the big piece was, again, as I pointed out a couple of times, one of the ways that this model works is when all staff in the office, in the clinic is trained, understands substance use disorders, right? Understands stigma, understands language and how to appropriately work with our patients. So that's really the key piece. So what do those training components include? Certainly the buprenorphine waiver training, also kind of buprenorphine 101 for all staff, which includes things like how do we work with individuals with substance use disorders, then ongoing shadowing opportunities, right? Email backup for satellite clinics, policy and procedure manual provided to different kind of community clinics. So like the academic center would provide this support to satellite clinic, kind of something similar to what we're doing here. And also billing support, really coming from help from the state. And yeah, this was kind of the key curriculum that was included. And that included a lot of things on buprenorphine, how the medicine works, things like confidentiality, drug-drug interactions, but also things like management issues. How do you deal with diversion? How do you deal with recurrence of use? How do you deal with legal issues, kind of patient flow issues, but also things like, kind of more general overarching education for all staff, including why should we be doing this in the first place? What's the reality? What does the law say? What can we do? What can we not do? So kind of really coming up with a comprehensive education. So that was one of the roles that the MD served under this model to really build up capacity across the system. Thank you. Next slide, please. I think, yeah. And I think just a couple of slides on, should I take this, Dr. Maley, or would you like to do the last? Okay. So as an administrator, I know we do have administrators joining our ECHO program, right? And I think there is clearly a big role for administration. If you look at like literature on barriers to why providers don't prescribe buprenorphine, one of the barriers that has come up historically in this literature is lack of support from administration, right? So that's why it's really critical. The administration really needs to also understand this. That's why I'm always glad when people from administration join our clinics, because I think even if you're not clinical, it really helps to understand some of these issues, because that then allows you to support the entire clinical team. Allow for regular meetings with open communication, and make sure there is appropriate staffing, coverage issues are addressed. Allow time for trainings and continuing education, which can be challenging, right, in our current environment. But as much as possible, I think allowing it ultimately supports that clinical team. And creating clinical policies and guidelines in conjunction with the team, seeking that input from the team. And I would really add to that, even seeking input from your clients, right? Engaging the clients in that process is also very important. So yeah, last slide, I think what we can do right now, important things, simple things, be an advocate for your patients, help create that accepting and patient-centered environment, work within the community and beyond to combat stigma, which is often such a major barrier to care for our patients, and work with tribal leadership, state leadership, even national leadership to really advocate for policies that will ultimately benefit our patients and our communities, right? Such as funding for treatment, drug take-back programs, education, youth engagement, naloxone distribution. So those are some things all of us, regardless of our role, can do even now. Thank you.